All right, so here we have Lieutenant Colonel William May, and I'm going to apologize ahead of time. I've done this a couple of times, and my microphone seems to be going in and out, but I think I've got most of it pretty good. So here we go. Okay, so Lieutenant Colonel William May, he prefers to be called Will. He's a 45 white male. He's been married for 20 years. He's in the Army Reserves now as a lieutenant colonel. He's been in the military for 27 years, but he's retiring next year. He's an electrical engineer and project manager for a big defense contractor. Today in the office, his initial vitals were heart rate was 60, blood pressure 125 on 70, respiration's 18, temperature was 98.4 degrees Fahrenheit. He is 6'3" and weighs 230 pounds. Will's last physical was an Army physical last month, and it was excellent. They had no findings other than some slight hearing loss in his left ear, thought to be due to noise pollution. He used to drive ambulances for the medics in the beginning. He's got some osteoarthritis in his knees. His EKG was clear. As far as allergies and vaccinations go, he had some seasonal allergies in the fall, but he manages them without medications. He doesn't have any drug allergies. His vaccinations are up to date with military requirements, which are beyond what our requirements are. His current medications include occasional Aleve for knee pain, one tablet twice a day as he needs it. He's been using some Gold Bond medicated powder for his groin. He was prescribed a nystatin, 1,000 units per gram 3 times a day, and a Lotrosome cream that he got over the counter 3 times a day. So Will was training one of his training weekends about 4 weeks ago, about a month. It was hot. It was humid. He came back after his training Sunday night and he noticed a rash in his groin. He's had a history of athlete's foot after his training ends and past when he was in the military full time, and he figured this was just the same thing, just a jacket in his groin. So he tried some over-the-counter powder, the Gold Bond medicated cream. He thinks it was Lotrimin jacket. He used this for about a week. The rash didn't get better. It actually got worse. And so he went to his provider and was prescribed nystatin and a Lotrosome cream with a diagnosis of tinea curis, complicated by candida. The rash seemed to get better for a few days, but now it's back and it's worse and it looks a little different. So he will complain of some burning, especially with the powder he was using, a mild pruritus, and no real pain. So he's had the rash for about 3 weeks. Upon exam, you notice that Will's got an erythematous brown rash with red brown macules. There's a distinct border. It has a wrinkled appearance. There's a very fine scale. It's bilateral on the scrotum and inner thigh and the inguinal fold. Mild maceration of the skin. There's no pustules, no satellite lesions, no central clearing of the main lesions. It doesn't involve the penis. And it isn't spreading down to the thighs or up into the buttocks. There's no excoriation or lichenification at this time. Based on this appearance and history, you think this might be erythrasma. So you pull out your trusty Woods ultraviolet light, turn out all the lights, and you shine it on the rash, and this is what you see. It glows, it fluoresces, a coral red rash, which is confirmation of erythrasma. The coral red fluorescence is due to the presence of porphyrins from the bacteria. You take the time to look everywhere else, especially in the folds of his skin, in his axilla, and anywhere else there's a fold. There's no lesions in the axilla, the interdigital spaces, especially the third and the fourth. He doesn't have any lesions there. You use the light to just double check. And while you're down there, you look for a fungal infection on his feet. You don't see that there either. Sometimes the fungal infection will glow a bright lime green in a woods light. Okay, so differential diagnosis. This is kind of a big slide. I don't want to read all of it, but The differential diagnosis for this type of rash is generally three things: erythrasma, tinea cruris, and candida cruris. The tinea was what he was being treated for, the presumptive diagnosis to begin with. There are a few ways that you can tell them apart. Um, the erythrasma is caused by a particular bacteria, Corynebacterium sorry, which is a normal flora of the skin. It's on healthy adults and it's not inflammatory, and that's key because the other two are an inflammatory process. Again, the most common place for the erythrasma to happen is in the fourth interdigital toe spaces. You can see them in the inframammary folds, the axilla of the groin. Um, any increase in moisture and warmth, tropical climates, obesity, especially type 2 diabetes, and sometimes if this starts to happen, there's erythrasma is happening over and over, or that might be your first indication that your patient may be developing type 2 diabetes. We see it in older adults and immunocompromised patients. The rash is uniformly brown, it's scaly, it's sharply demarcated. It doesn't have an advancing border. There is like a half moon shape or a bilateral plaque within that coral fold. And again, it fluoresces coral red with the wood slate. Whereas the tinea cruris has a semi-different pattern, still kind of has that bilateral half moon shape, still in the coral fold, but it will have these satellite lesions sometimes, and it can clear, so it'll have like a central clearing. Some of these satellite lesions can even be circular, and it's not uncommon for this to spread to other places in the body. People will have it on their feet, and they'll put their underwear on and pull it up into their groin, and then it spreads to the groin, and then they touch it, and they touch other places in their body, and all of a sudden they've got tinea everywhere. So on the acute stages, you've got an exudate, it's inflamed, erythematous papules, they can extend up and under the buttocks and the perineum. The penis is usually spared. It really burns, it really itches, it can be very uncomfortable. And generally it doesn't fluoresce with a wood slate, or if it does fluoresce, it's a lime green. Ringworm is a very stereotypical lime green. And then you've got yeast, and that doesn't fluoresce. If you're going to use a potassium hydroxide slide, can be helpful when you're looking for this. You won't see the hyphae if it's erythrasma. If it's candida, you would. The rash looks different. It's got this kind of central rash with these papules kind of speckled around the outsides. It's very itchy. You'll see a lot of expiration sometimes. It will involve the scrotum, penis or labia. And you can also see this candida as a co-infection with the tinea, or you can see it with the erythrasma, all three. You can get all three. So it's good to know what the different rashes look like. So we've decided this is erythrasma. So what are we going to do? We've got a couple options. And experts differ with what they like to start with. Sanford says we want to start with a topical. So a topical clindamycin or an erythromycin is applied 2 or 3 times a day for 2 weeks. Some topical antibiotics can contain alcohol, and it can be irritating. So there are some studies that say mupirocin 2% ointment is shown to be very effective with very little to no reoccurrence of rash after 2 to 4 weeks. You've got the oral antibiotics, erythromycin, 250 milligrams 4 times a day, which is hard for a lot of people to do for 5 days, or clarithromycin single 1 gram dose, or clarithromycin 500 milligrams PO BID for 14 days. You've also got the topical antifungals, so the miconazole, the clotrimazole. They're specific to say no ketoconazole. And especially this is useful with, excuse me, co-infections of erythrasma with the tinea or the candida. You can get a clotrimazole betamethasone dipropionate 1% topical cream that's prescribed, and apply that twice a day for a week. And that can do a little bit better job than some of the over-the-counter things that they could use. So we're going to start with the clindamycin 1% lotion. You can put it on 2 to 3 times a day for 2 weeks. This should work well for an aerobic gram-positive cocci like this. You do need to talk to them about the different types of reactions you can see with antibiotics. C. diff and associated diarrhea. This is a topical solution that's generally not something that you're going to worry about. You can worry about a hypersensitivity reaction even with a topical, so they need to work for worsening rash, a fever, and anaphylaxis. Increase in itching, especially if it spreads to other places other than the groin, the palms, the skin, difficulty breathing, that sort of thing. Like, common side effects of this topical medication include burning at the application site, itching, dryness, a little bit more redness. It can make your skin a little oily. The skin can peel, and that will happen just as a result of the healing from the infection as well. Sanford also lists as headache, contact dermatitis, abdominal pain. Some other things that Will can do to help along the healing of this infection. And one of them is to use an antimicrobial soap. And he's got two options. One's a little easier than the other. You've got Dial soap. Um, you get the Dial antibacterial soap. Wash with that every day. Tell him to use the Dial on clean hands. Soap his hands up. Put the Dial down, and then clean his groin. You don't want to use the soap directly on the groin. It is an antibacterial soap, but keeping cross-contamination as clean as possible. If he uses a washcloth, make sure that washcloth is a one-use only and it gets washed in hot soapy water, blah, blah, blah. You can also use a HebaCleanse solution, the chlorhexidine gluconate. That you can get at CVS as well or any other drugstore. HebaCleanse can be a lot more drying, especially in the groin area, so he needs to be careful to try and keep it just in the groin area. Wear loose-fitting trousers if possible. After you get out of the shower, try to air dry the whole groin area. Dry it well. If you're using a towel, again, make sure it's a once and done. Get rid of it. Wash it. I wouldn't use the antifungal powder that he's been using, especially when it's got the menthol in it. That's going to be super irritating right now. In the future, if he wants to use a mentholated powder or a Gold Bond powder, as a preventative when he's in a place where he's going to get a lot of moisture in his groin, then maybe a non-mentholated Gold Bond. They've got a powder aerosol. It seems a little bit easier to use and it's a little kinder on the skin. And just again, shower, dry, apply the powder. So Will should see some improvement in 3 to 4 days. It's going to take 2 to 4 weeks for a greater change. So he needs to call the office if he doesn't see any improvement at all after 7 days. He needs to call if the rash spreads in the groin, if it worsens, if it appears in other areas of the body. And it's not listed here, but also definitely call if you're starting to notice any of those warning signs and symptoms with the medications that we talked about previously. The topical therapy isn't working for Will, then there is the option of systemic therapy and oral medication. Generally, it's indicated, according to Stanford Guide, for widespread disease or resistant local infection. There are a lot of dermatological sites and dermatologists who recommend just starting with these PO meds. So, it's going to have to be your choice here. But if you don't see an improvement after 14 days with Will's rash or it worsens, we can do an oral erythromycin, the 250 milligrams 4 times a day for 5 days, which is kind of rough. And you've got all those normal things to watch out for, the hypersensitivity reactions, the nausea, vomiting, diarrhea, the C. diff. With erythromycin and statins, and Will's not on a statin, but if he were, this wouldn't be the best choice because the erythromycin can elevate the statin levels with concurrent use. With clarithromycin, you have a choice between 500 milligrams PO twice a day for 14 days or a one-time dose of 1 gram. This carries along with it, we have to warn them about superinfection, C. diff. It does have that QT prolongation. It is associated with some hearing loss, though reversible. You've got the anaphylaxis. You have to warn them for the symptoms of that. You've got Stevens-Johnson syndrome and toxic epidermal necrolysis. So warning them about the symptoms to watch for. It begins like a flu-like symptoms and a rash, and goes on from there. And more common reactions includes your GI disturbances, the nausea, the vomiting, the diarrhea, and specifically with clarithromycin, you can get